I decided to go into healthcare, particularly because I wanted to figure out a path to connect that desire to understand the context of our lives, the political and social kind of experience of our lives, in the same way it shaped my parents' lives, but do so in a way that allowed me to kind of help people individually.
Hello, everyone, and thank you for listening. Today, I'm speaking with Dr. Rishi Manchanda, founder and CEO of HealthBegins, a social enterprise that provides training, clinic redesign, and technology to transform healthcare and the social determinants of health. Rishi is a dual board certified internist and pediatrician. He's a board member of the National Physicians Alliance. He's a fellow in the California Healthcare Foundation's Healthcare Leadership Program. He's still a practicing physician, providing primary care for homeless veterans at the VA in Los Angeles, and much, much more. Rishi, thanks so much for chatting with me today. Before we get deeper into the podcast, maybe you could take a few moments to just introduce yourself and your background.
Sure. Thanks, Ohad, and thanks for inviting me. Hi, everybody, and hi to you. I live in Los Angeles. I am proud father to two kids, been married for just over 20 years right now, and have the privilege of being involved trained as a physician, being involved in leading an organization called HealthBegins, and being able to draw in that work on my years of experience providing care and redesigning kind of care and working with all the tools and the partners that we can to be able to improve care, particularly for folks who are harmed by societal practices, or to put it another way, who have a hard time making ends meet, who sometimes are experiencing upstream challenges like food insecurity and housing instability and an acute income loss or change in their lives. For folks who sometimes fall in hard times, just need a better model of care, and that's what I spend my time doing.
I'm so excited to get deeper into this because I think many of us that work in healthcare feel that we're good at dealing with the clinical situation and maybe are more reticent and maybe less secure to step back and think about what can we do to deal with a lot of these upstream factors. So there's so much to talk about today, but maybe first, let's try to just kind of trail your background and how you got into this space. I know you're from the Northeast originally. How did you get into medicine? What drew you into this field?
Yeah, the quick kind of story. I'll go way back in time to where I come from, and then where I got to speed up to where I got to now. So I'm first. It's important to state I'm the son of two immigrants who are from India. My father was born just a few years before India became independent. My mother was born the year India became independent, and both of them were part of a massive partition that happened at the same time when India became independent. So when India and Pakistan formed, which means that growing up, I heard all the stories of both that you can imagine. Imagine if you were the child of people who were alive at the founding of the US, right? But not like the stories that you hear are the stories of a new nation in that kind of way. And I'm welcome your kind of thoughts on this as well. And those stories are different from somebody who's many generations later. But those stories also taught me the story of what it means to understand how the forces outside of us, the forces of like politics, can actually shape your lives. So partition, for example, that always was part of my story. This understanding of how the bigger environment, the world, the things we can't see and touch, actually have real concrete implications for the stories we tell ourselves and the experiences we have. I decided to go into healthcare, particularly because I wanted to figure out a path to connect that desire to understand the context of our lives, the political and social kind of experience of our lives, in the same way it shaped my parents' lives, but do so in a way that allowed me to kind of help people individually. So clinical medicine and social medicine in particular became my calling. I was born in New York. We moved around quite a bit, spent time growing up in Texas, then India for a few years, came back around to the Northeast, and then finished my medical and public health training in Boston. And then, as I shared with you earlier, my then fiance, now wife, said, if you want to stay together, find someplace warm. So we came to Los Angeles, and I've been here in Los Angeles for over 20 years. And the work that I've done since then has allowed me to be able to connect the dots between what it means to be, a person who has health issues, right? If you're a patient of mine, but also a person who lives in a family, in a community, in a network. And sometimes if you're someone who's experiencing challenges like with food or housing or other things, the kind of care that I've always been compelled to kind of want to provide is one that connects the experience of that person with the broader environment they live in, and how can we create models of care that allow us to understand and address those upstream issues has been a driver for me. So I kind of found myself in this path many years ago, knowing that I wanted to do work at the intersection of what we classically consider to be kind of just direct patient care and work in the community and work in these broader social contexts. That work has been the animating kind of part of my career, and I've been fortunate to kind of find a path to let me do that ever since.
Was there an event, Rishi, or an experience that kind of caused you to increase your aperture, right? Because when you're a young physician and you've got a dual certification and two fellowships, and
Yeah,
like it's very easy to get caught up in the clinical, right? In kind of making your career, making your name, learning. There's so much to learn as a physician in
yeah,
these two spaces. What kind of caused you to step back and think about what else is causing? I mean, I appreciate you connected it to your background, and that's really
yeah,
interesting
yeah.
to think about. We are kind of who we are as part of a byproduct of what's happening around us, and I guess that's true in healthcare as well. But just unpack that for me a bit more. I'm really interested.
Yeah, it was probably a series of different events that led to this. So, growing up again, with the immigrant background, especially being in the US and then moving around as much as I did from the US to India and back and forth, it meant that I was always in between. I was always living in a kind of a hyphenated place, right?
Hmm.
Indian American. I was in India, I was the American kid. When I was in the US, I was the Indian kid. And you understand like how that when you live in between spaces, you understand every place then has a different set of norms, culture, language, food. It would be Chuck E. Cheese in Houston versus, Chole Bhatura in New Delhi. When you understand like that every place has its own particular culture, every particular set of norms, and every particular set of resources and opportunities. As a kid, I think that made me always curious about this, or always aware of it at the very least. This middle space. In college, I took a transformational course for me in my junior year called the Political Economy of World Hunger. It was a pretty heady name.
Hmm.
It was taught by this great group of this great professor, excuse me, who had worked with UNICEF and had this just wonderful way of connecting the dots to like really something very acute, which is hunger, right? And experienced around the world, but put it into the context of the political environment and the social environment in different places, and talked about how hunger looked different in different parts of the world, and how hunger wasn't a given, right? But it comes about because of policy choices people made, and it just opened my mind's eye to thinking about the policy world, these invisible things that shape our lives. And I could understand that, could relate to that, because I was like, oh yeah, I could see how policy changes shape my own life, my parents' life, my grandparents' life. I was so enthused by that course in college that I decided to take a year off after college and go to India and work there, both because of personal connections, wanting to kind of connect with my roots, if you will, but also because I wanted to explore this intersection of, community and context and how that shapes, in that case, health. And I came across a lot of different folks who I later adopted as mentors, who were physicians who happened to be as adept at taking care of patients in their clinic on a Monday, and then on Tuesday be able to go out and be part of a community effort to, improve sanitation, or to show up on a Wednesday then at the local town council or town hall and talk about issues of public health or about something else that didn't seem to even have health as implication. These were people who were advocating for improving health, but doing so in a way that kind of crossed these traditional boundaries, moving in the hyphens, right? They were doctor, public health worker, advocate
Hmm.
all at the same time. And I was like, I get that. I like that. How can I do that? And I came back and I started talking to folks I knew in med schools, and I asked, hey, can I do something like that? I'm at one particular kind of med school dean that I connected to, and I was like, I have all the prerequisites. I was interested in this, but I'm not sure if this is what I want to do. But I want to instead be kind of a doctor and a public health person, a doctor and a community kind of organizing kind of person. I want to be able to solve problems in the hyphens. And this dean said, look, if you want to take a year and do what you're doing in India, then come back and join us. We can take care of you. This is perfect. If you want to, just let us know when you're ready. And that was the first time somebody had said yes to a kind of question I asked, and it taught me something early as well, which is it never hurts to ask. After finishing up my medical degree and my public health degree and taking another year off to come do some work in the field, I worked in Botswana and came across some mentors who let me kind of work with them in issues of HIV and tuberculosis in South Africa and Botswana and Mozambique. An incredible experience there, and it allowed me to kind of be in the field, which is something else I loved. I just being in community is what gives me energy. Being especially in places that some of us look at, maybe and view it as an exotic or a distant kind of land. When you go to these places, of course, you realize first of all there's a lot more that we have in common than that's different, and that there's such wisdom in places that often it aren't seen in that kind of way, right? Like the innovations that I learned in rural communities in South Africa are things that are way more innovative than I would than some of the things that pass for quote unquote.
Because the necessity has to drive that innovation, right? And you have such
Exactly.
limited resources there.
Exactly. Those lessons were formative for me, and I think that's again, there's a series of different events that led to this. And when I came back and decided to go into do medicine and public health and have those experiences there, I just learned if the silos don't let me kind of, if I can't fit within the silo, I'm a hyphenated kid, I'm a hyphenated guy, I live between spaces. I want, I want to understand specific disciplines really well and then be able to connect the dots between these disciplines to each other, medicine and public health, healthcare and technology, the clinical world and the social kind of world. There's so much richness that's there. That's the stuff that animates me. That's the stuff that gets me going. And what I've just done in my career is realize that it doesn't hurt to ask questions when you have that interest in those intersections. And every opportunity I've had has really been born out of me asking a question about somebody who is at the intersection of those two things. And then that would open up an opportunity.
And it sounds like those roles didn't necessarily exist. This pathway didn't exist, but you created it for yourself because you were that hybrid, hyphenated, straddling multiple roles. I always say, like, if you can't change your world, change yourself. But if you can't change yourself, change your world. And sounds like that's what's been driving you. I certainly feel the same. We talked a little bit about correlations in our history and our lives. I see a lot of that too. I'm really intrigued by one thing you mentioned, though, that kind of your interest in social justice stemmed from your exposure to seeing this internationally. And that's something that myself I find challenging. And I've heard this from other people where it's kind of easy to go and travel the world and go volunteer and feel very compassionate, connected to, global health initiative in Botswana. And then it's a lot harder to come back here to Vancouver and find the same sympathy and compassion and willingness to devote my time to homeless people, unhoused people in the Lower East Side of Vancouver. And why is that, do you think? I'm just curious because you were able to kind of take your energy from outside and bring it back into all the challenges we face here in North America. And yet I find for me, and maybe for others, there's a little bit of more of a dichotomy, kind of what happens outside of here versus here is my focus, my energy is very different.
Yeah, that's interesting. I had maybe a different experience. If anything, I felt like more at home in sometimes when I was abroad, and then I'd come here and I'd go, why are people not having that same kind of dialogue here? It was always that phenomenon of being able to see the other, right, as ourselves is something that some folks will get when they travel elsewhere. They'll be like, oh no, I gained so much from that. I can see myself and somebody else from another world. And then we come back here and then we other somebody else. Then we get back to othering. We get back to
exactly
separate. So I think part of it is just a tribal kind of thing that we have to get past. Like we default into these modes of being like, okay, now we're in our home base right now, and who is in the in group and who's in the out group right now, and so we other people, and that's a real human kind of tendency that we do. Of course, it's baked into who we are, but it's also something that it can drain empathy, it can drain joy out of our lives. It can also drain the source of what animates me a lot, which is the ability to see myself in others and also to see others in myself, to kind of just connect. We sometimes folks recharge by going outside and traveling abroad, and then to kind of refuel and recharge and kind of see the world and then come back. That's an artificial divide, right? So there's something about the othering, this idea of what it means to other, and the fact that sometimes going abroad and coming back home leads to it implicates what we do in terms of othering people. The other thing, of course, is like there's an exoticization, right? We exoticize. There's a lot of folks who will say, "Oh, those poor places in the world," right? And thank goodness for us here, right? And so we kind of create this artificial divide, thinking that it's those poor people, right? We exoticize. We tend to create an image that's entirely disconnected from, we stereotype, right? And
their poverty is exotic. Our poverty here in our backyard is just sad, right? And so
yeah, exactly. And therefore something we can't really change. It's just a given. And that's the last part of it, I think, to your point, that it's the sense of it's the last lack of agency, right? We can pontificate on like, oh, woe is them, X part of the country. Like, it's clear that there's policy choices that people have made there, and that's what's led to maybe some poverty. But here, it's just the way it is, right? We kind of resign to it. I think resignation is a big part of it. And again, because I've always, to your earlier quote, the world and yourself both are changeable. right?
Hmm.
Both need to be changed. We're growing people. We're learning people. Otherwise, what's the point of being on this planet if you're not always learning and always growing and always helping? For me, the ability to, if we say I'm someone who's always trying to learn, I'm always being on the cutting edge, I have a growth mindset, whatever phrases we use these days to talk about that stuff. If we don't, we somehow, I meet a lot of folks who then check that at the door when it comes into social policy. It's like, okay, somehow the ills of the world I can't change, but everything else I can change. Everything else
Hmm.
I can create a new product, right, to solve a problem. I can innovate like the best of them. I want to always be growing and learning, etc. But when it comes to these things that are like homelessness or hunger in the world or problems that afflict folks, that's a given. Oh, I can't do that. That's too complex. That's something that's insurmountable. Like we end up almost like doing the exact opposite of a growth mindset when it comes to things
Hmm.
perceived to be.
Those are actually great problems for us to innovate on.
Those are the problems I think that are.
Exactly, they're the big ones. And so maybe that's a good segue into to help begin. So kind of you come up
Yeah.
through your educational background, you're getting exposure through these various initiatives that you've undertaken to social justice and how the intersection of that and healthcare. What leads you to then become an entrepreneur, a founder, to say, hey, I'm going to actually do something about it? And like you said, these are the most important problems to solve. I'm going to innovate and look for new approaches. Tell me about that.
So when I came to LA, I came here to do my residency training to kind of learn to be a internist and a pediatrician, adults and kids. That program didn't exist. I asked a question. I was like, hey, can I do both? And I was fortunate to find folks at UCLA to agree to this kind of question. So again, I was learning, just ask, and no is the worst answer you can get. I finished the training there, and then I went to go fulfill a commitment to a program called the National Health Service Corps, which in the US is a program that not many folks know about. It's a program that essentially says, we will pay for med school, the government. In return, you as a doctor have to work in the most underserved communities in the US. So I went to go work effectively in South Central Los Angeles for 4 years, caring for patients, for families, working families, poor families. And it was a phenomenal experience. And I did full-time primary care, built a program called a social medicine program to help connect what we were doing in the clinic to the community. It was great. But I didn't really have a community. I didn't really have of professionals. I didn't really have peers that I could talk to all the time. I'd go to various conferences, medical conferences, when I had time to do that, or I'd go online and look around to kind of connect with folks. And I knew I wasn't the only one. I knew that I had a smattering of kind of folks in my network, but I knew there was many more of us out there, many more folks who were interested in healthcare, in optimizing healthcare and making it better by understanding and addressing the upstream issues that make people sick in the first place. After looking for a number of years, I couldn't find it. And I was like, all right, we'll create an online network. HealthBegins was formed initially as a network in 2012, just to connect people of like mind to each other so that clinicians like myself could swap notes with other clinicians about, hey, you're screening for food insecurity in your clinic. Hey, can I borrow that screening item? Hey, you're connecting your patients, not just to cardiologists, but to community health workers to kind of take care of the mold issues in their home that's making them sick with their asthma. Oh, that's cool. Can I borrow? So it became a network to kind of swap notes. And it quickly morphed into a training organization when I started getting inbound requests from a variety of folks from the federal government in the US to community health centers and a variety of other folks saying, hey, can you train us? But it remained a labor of love. In 2017, in the US, a major initiative by the folks who lead Medicare and Medicaid started to come into shape. It was a project to see if screening for social needs could actually improve outcomes for Medicaid and Medicare beneficiaries, people who have that public insurance program. And I got called up and they said, hey, it sounds like you've been working at this for some time. Can you help us to support this program, to provide technical assistance to all the organizations that are going to test this model across the country? And that's when I was like, wait, I think now the nation's kind of caught up with what I've been saying for a while, which is we got to address these upstream issues. Maybe I can make this full time. So since 2017, after a variety of different projects working at South Central, I went to the VA. I was there for actually 4 years. I'm no longer at the VA. I worked there for 4 years, built a clinic for homeless veterans. I was there with a phenomenal group of people, including the veterans themselves, demonstrated incredible outcomes by being able to kind of reorganize care. We brought in lawyers and social workers to the clinic, right, to help improve outcomes. So doctors and lawyers working together. It actually worked. And then went to the Central Valley of California to build clinics for farm workers for a large company. And we built clinics from scratch and did that. So I've had these clinical experiences. HealthBegins, I decided to make full-time in 2017 when that federal initiative came about. And for the past 7 years, what we've been doing is working with hospitals and healthcare clinics around the country, as well as their insurance providers, to be able to reorganize care in the way that I've seen and I've done in my career, which is to integrate social services and healthcare together. So that when patients are showing up, patients with diabetes are showing up in the clinic and they need insulin, but they don't have a fridge to store it in. How do you solve for that?
Mm-hmm.
If you have a kid with asthma and they keep on bouncing in and out of the ER, and it's because of the roach infestation in their home that their landlord is not taking care of, how do you solve for that? If you have patients who are with congestive heart failure who are getting sicker and sicker and needing more intensive care, but can actually get better with a medically tailored meal that can be delivered to their home rather than having them admitted to the hospital? How do you solve for that? We are the consulting firm now that helps these healthcare institutions move upstream to solve for those kind of problems, and to do so with an explicit focus, a very explicit focus on identifying disparities or inequities, using the data to tell us who is not getting the best quality of care, who is not getting the kind of who's suffering the most, who's experiencing the most harm right now, and how do we then address these upstream issues to be able to help reduce that harm. That's
But
what.
if we step back, I mean, isn't the root of that tied to the reimbursement model, right? At the end of the day, outside of CMS and has specific programs like Medicaid and maybe a handful of value-based providers, principally in the US and actually everywhere in North America, we're mired kind of in a fee-for-service environment where you don't have alignment of incentives to promote prevention, alignment of incentives to deal with upstream factors, right? You're kind of dealing with the sick and you're prescribing more or less procedures or drugs to that population. So can you, like, when you think about the clients that you serve today in your consulting practice, who are they, right? Are they only value-based systems, or can we find ways to think about healthcare finances, healthcare reimbursement differently to provide more incentives for additional providers or health networks to think about these challenges systemically?
Yeah, you're exactly right. If we're truly moving upstream, we have to talk not just about like who is getting sick and how to prevent that, but also how we pay for healthcare itself and pay for health more broadly, not just healthcare. So you're exactly right. I think that there are what's clear among our client base, which include a lot of folks who are the health plans, who are supporting fee-for-service arrangements, but also now starting to move towards value-based contracts. When we talk about the provider systems, many of whom are now engaging in and getting more and more interested in value-based contracts, that's certainly a driver. But to your point, many of them are still mired in the fee-for-service modeling primarily. And I think there's a kind of a continuum here of opportunities we're seeing. For example, in the fee-for-service space, even in the fee-for-service environment, new regulatory requirements in the US, at least, for Medicaid and Medicare Advantages in particular, is requiring healthcare providers, because of the evidence, the science that says that these social upstream issues are driving poor outcomes. There's regulatory requirements now upon health plans and providers to at least screen for and start to address those social needs,
Mm-hmm.
even in a fee-for-service environment. Is the reimbursement enough for that? Not enough, but the requirements are there. So now it's not just the reimbursement as a carrot, but there's a stick of the regulation, right? That's in there as well. So that's in place in the fee-for-service space. On top of that, there is these alternative payment models that are emerging, right, as well, that aren't full capitated risk, full kind of shared savings, full value-based care kind of arrangements, but enough now of incentives that are out there for performance, right, for a variety of quality measures, pay for performance kind of measures that are now including also equity and social needs kind of considerations there as well. So even outside of classic fee-for-service and the kind of alternative payment models and pay for performance kinds of models that we're seeing, that's also an incentive. So we're seeing a lot of clients who are coming in and saying, oh, look, we need to go for those incentives. Let's address the social risk factors and the inequities that the payers are putting into the mix here for us to consider. And then beyond that, for full value-based contract as well, I think there's more and more incentives that we're seeing in those spaces. So I think along the continuum, depending on where the plans are at, the providers are at, they're reaching out to us and saying, help us. We're seeing the last thing though, that's interesting outside that this is what implicates not just healthcare, but the broader public health community in the US. In the US, what we've done is a really great job of decoupling. By great, I mean that entirely sarcastically. Really great job of decoupling healthcare from public health. We're solving, in many ways, you could argue, and I'm chief among those who argue that a lot of what needs to happen is not just integrating healthcare and social care, just like we want to integrate healthcare and behavioral health. It just makes sense to be able to kind of have a healthcare system that's able to be really adept at connecting you to a social resource if that's what you need, just like, I can refer you to a cardiologist if that's what you need. We should be able to have a system that just makes sense from a biopsychosocial model of care. That's the highest standard of care. But beyond that, what happens when there's so many unmet social needs in given populations because of things that are outside of healthcare, because of social policy choices, right, that are being made? What happens when should healthcare now take on the job of fixing the food desert?
All ills of society.
Right, exactly. And the answer obviously is no. Healthcare would be really bad at that. We already spend in the US way too much money, like for very little value in healthcare. So it's probably not a good idea for healthcare now to become the problem solver for social ills when we haven't even had healthcare fix the healthcare ills, right?
Hmm.
But it does mean that it raises this question about what it means for the public, for the commons. Increasingly, that's the space that we see, and this is what we're playing a role in doing, helping bring together those plans and providers and the community organizations that are in given communities and saying, look, there are things that are beyond your ability to integrate with each other that need to have a common solution, a public solution, a place-based solution here. So, for example, flu vaccination or COVID vaccination, a few years ago was a major priority. Every plan, every provider doing that independently made no sense, right? It made sense community by community for plans and providers and public health departments to come together and share data, share notes, identify a goal, and then say, hey, okay, you're working that neighborhood, that zip code, I'll work in this neighborhood and zip code. Let's coordinate our work so we can improve this. It turns out in healthcare, there's a lot of challenges that are best solved by place-based solutions rather than have each plan, each provider just duplicate the
Hmm.
solution. So we do need solutions where we're coordinating by place. And lastly, also investing into the infrastructure to solve things at a public problem. In other words, have healthcare take some of its dollars, as is required in more and more places right now, and reinvest that. Can we reinvest some of the healthcare dollars upstream to be able to support the local infrastructure, for example, of just data exchange, right? Like health information exchanges are a big part of what's happening now in many communities in the US. To be able to fund that, to be able to have some sort of infrastructure where the data can just be shared within folks, we need some funding source from that. And it kind of makes sense, I think, to tap into a variety of sources, including healthcare dollars. So I think there's solutions at the program kind of integration level, at the point of service, if you will. Technology plays a huge role in that. There's also solutions to be able to help coordinate place-based approaches for things that require, like COVID vaccinations, flu vaccinations, and things like that, that just require coordination.
Hmm.
Technology can help solve for that too and support that. And then there are solutions to be able to help better pool resources and reinvest resources to pay for the commons, right? To essentially say, does it make sense if I need to get from point A to point B, should I hire a bunch of private companies to be able to build the road each step of the way? Or should we all pool our resources and pay taxes, right? So that the public entity kind of pays for the road that we all benefit from. Same thing over here. We need to kind of invest in the so-called roads, right, of health.
In the infrastructure, the big picture that's ultimately driving
That's right.
the disease state.
And there are technology solutions there that can be really helpful. And there's some great examples of actually some ways to be able to help, especially with big data plays and with some other technology solutions to be able to help adjudicate the transferring of funds and the tracking of the funds there and to be able to track the impacts of those funds. Technology can play a major role in that.
Yeah, I'd love to unpack that because I've heard a great call to action in your remarks for providers about thinking more broadly about more interconnectivity for payers in really being geared and honed towards many of the emerging programs around quality and generally kind of thinking more broadly about how we tie the payer provider landscape together. Let's maybe move to the private sector, technology companies. A lot of our listeners are health tech entrepreneurs. You've talked a little bit about how technology can facilitate a more open exchange of information, right? We know that one of the anchors for value-based care is the ability to actually measure outcomes and know whether what we're doing has a positive impact or a negative and adjust based on that and measure as a means for rewarding and incentivizing. Where else can technology play a role in this more integrated, more socially oriented healthcare environment that you're looking ahead into the future?
Yeah, I think one of the primary ways, I'll put two kind of things out there. One is to leverage the technology can play a role in actually leveraging place, and I'll come back and unpack what I mean by that. The role, being able to understand items and issues and solutions by place. The other way I think is being able to help shift payments and power. I'll unpack that too. So let me talk about by place. We know that in a lot of healthcare, for example, there are a lot of point solutions. There's a lot of wonderful technologies and also analytical tools that allow us to be able to, slice and dice the data and to be able to look for outcomes and improve, look for opportunities to improve outcomes in a variety of ways. We can look at data by payer type, for example. We can look at data by certain demographics. We can look at utilization, right, outcomes, and be able to say which patient population will benefit the most from this solution, from that solution. One of the things that's not commonly done still, especially in the US, is being able to analyze opportunities, the data sets that we have by place, right? We don't do that because in healthcare in the US, we've kind of forgotten about using place.
By geographical place or by care setting?
By both, by care setting and also by geographical setting. And also to the extension of that, of like data that tells us about where people are spending their time, right, as well. Because we know the science tells us that the built environment, the physical environment, the natural environment of our lives, it influences so much about our health experiences, both in terms of access to healthcare, access to a variety of other health promoting kind of things, as well as proximity to health risks as well, right? Air pollution, things like that. The ability to parse data by place is, I think, a really key part of being able to unpack opportunities for a variety of solutions, and also to provide healthcare insights into the nature of certain problems. So that's the first facet, very easy. But the other is actually starting to leverage that awareness of place into point solutions. So I'll give you a really good example. A company now, I think it's called Propeller Health. It used to be called something else before. This is a company that was providing a medtech solution, which was a better way of helping asthmatic patients, kids included, to be able to improve outcomes. And what they did was to embed essentially a chip to track GPS locations in the inhalers and track the usage, right, of the inhalers by place, and then let that provide insights into where there was real-time data about asthma hotspots kind of coming about. That data was hugely important. That point solution, right, was now tapping into the power of place to not, the data wasn't helping the end user, the patient in this case. It was helping those who care about that end user in terms of how much, how their health is, how much they're spending, right, on that end user.
Where are they getting exacerbated? I understand that. That's very interesting. So that's both where are they applying the medication, but also where do we have hotspots of their incidences of people, children needing asthmatic treatments?
So, when there's some point solutions and some technologies that are not tied to a care setting, like a solution that's required in a hospital or a clinic to be administered, but actually are mobile, right, working, moving across locations with a person. The ability to track that information and that data by place is invaluable to give insights, not only for the company themselves and the client, but also can be leveraged to be able to inform, data for public health purposes, right? Or for a group of kind of clients as well. There's just valuable insights that we often just leave on the table when we don't tag the information by GPS, and then to analyze that alongside other indicators of health to be able to look for.
That is a great tip to medtech companies to think about that other dimension of what they do, of like, where is the service being delivered? Where is the product being used? And like you said, technology-wise, easy to accomplish with what's available commercially today.
And there's many spin-off things that kind of flow from that, right? Like the ability, and this also became clear during the pandemic, certainly, some companies that were not traditionally even seen as kind of pioneers in public health, but were just happened to have products in people's hands, right, were really helpful in being able to help support public health interventions, in this case, the response to a pandemic, but you could take that to any number of public health solutions. So for example, there are those who provide durable medical equipment, right, or equipment to those with disabilities, right, those products. That information set, right, that a DME provider has about people's locations can be very helpful data, right, to inform outreach efforts when you're trying to help get a public health campaign mounted. In other words, it doesn't have to be just kind of putting a GPS chip into a product. It can also just be looking at your data that you have as a company by place and starting to look for patterns that exist even among your own clients or your end users, right? To understand where there's disparities, outcomes, not just personas, right, for marketing purposes, but also like user experiences and what is place telling us about the different subpopulations, the clusters of folks who are acting differently.
No, that's fascinating. Before we come back to your second point around payments and power, I just want to react to that location, because in many ways, our company, like, we are predicated on the belief that ultrasound will proliferate from being kind of buried in the basement of the hospital in radiology and cardiology, and will move into the community. And our company's on a mission to touch 30 million lives by 2030. And we're only going to do that by getting into care settings where medical imaging was not available before, and getting into the hands of practitioners and users that never dreamed they could use an ultrasound, afford an ultrasound, have space for an ultrasound. And so I think that many technology companies in medtech can think about that similarly, to your point around not just how can we have better health policy by proliferating the settings where ultrasound is being used or whatever technology is being used, but rather also by using that to create and to grow more commercial opportunity for them by increasing their total addressable market, by understanding how can I create new use patterns and new care settings where my product could be applicable. So that's, I think, a great call to action for anyone in medtech listening, is to think about how do you break from the traditional mold of where your product was being used and think about new ways, new areas, new locations, new users that could benefit from it and care for patients using your technology.
Oh, I really like that. And I think one of the things that it has implications for those who are new entrants, right? Kind of trying to get into a market, as well as those who already have some traction and some data. To what extent can an analysis of place, right, help you now to get better inroads, right, in with some clients,
Mhm.
as well as to be able to now, if you have traction, be able to analyze your opportunities and go forward in that way. And that's maybe a segue to this other kind of part of it, this payments and power part of it. We have, I think, some really interesting opportunities. I'll give you one example of a great organization called Health Tech for Medicaid. It's a group that I serve as an advisor to. It's a group that is meant to help provide a lot of health tech companies, including some med tech companies that are trying to, in the US, address the Medicaid market, right? The growing kind of Medicaid market that's there, long been ignored by innovators, right, and technology companies. But because of how pervasive, Medicaid touches 1 in 3 Americans, sometimes 1 in 2, depending on the communities that you're in. So it's a huge program. This organization, Health Tech for Medicaid, has become a clearinghouse, a way station for folks that's coming together, for innovators to come together and talk about issues. In that space, when you have technology companies now, med tech companies included, who are now looking at things by place, you can come into the trade associations, the groups, the peer networks that exist, the places like Health Tech for Medicaid, and start to swap notes about common challenges, right, that we're seeing. So let's say, for example, that there's cold spots that you might have, right, in your data of ultrasound uptake, right, in Canada or in the US or around the world. What if it, like, your data tells you that there's not penetration into these communities geographically by place? Conversely, hotspots, like where are we seeing a lot of uptake, like the care settings, right, that are using this a lot? Sharing notes with each other, right, might reveal that there's something upstream of our particular client relationship or marketing strategy here that's causing this. It might be that there is a payment issue at
Mhm.
play right now, not enough incentives, right? Not enough kind of, there may be barriers in terms of regulations, et cetera. Something that's making that cold spot a cold spot, and conversely, something that's making the hotspot a hotspot. What is it about that? What is it about that analysis of place that now allows us to be able to identify if there's some barriers, upstream barriers that are taking place, and how can you individually as a company, as well as with other peers, associations and others, now start to kind of point the finger at those barriers, those upstream barriers, not just to your
Mhm.
technology being adopted and opening up that addressable market, but also to address something that might be implicating other technology providers, other solution providers, including the caregivers themselves, right, to provide that care.
Maybe a need for a reimbursement code or something to that effect, right? That could
Right.
help stimulate adoption where you're not seeing it today.
One company called, it's now called Same Sky Health. They just got, I was talking to them this morning. They were just acquired by Ground Game Health. It was started out as a company that was using text-based messages to try to drive engagement, especially for communities that are ethnically diverse, right, who speak, and linguistically diverse as well, and really tailored from the ground up to be able to help address the needs of folks who speak different languages, come from different cultures, to be able to drive engagement. Their health plans were their market. One of the things that they found was that as they talked to the plans, a barrier that kept on coming up was a regulatory barrier at the state level in California, and similarly then at the federal level, where text-based messaging was just, there was challenges in terms of what health plans could do because of this challenge, right? It was there's, the plans would say, oh, we can't do this because, or we're concerned about this because of our interpretation of this one regulation. So the company, Abner Mason was their CEO, then rallied together with others in this health tech for Medicaid space and said, all right, we need to kind of figure out a way, as essentially a trade association right now for this particular set of beneficiaries, Medicaid, how to provide our guidance. These are technology providers who are pointing to a regulatory barrier that only technology providers could kind of see and had a vested interest in addressing, that allowed them to be able to name something that had implications not just for their own technologies and their own kind of companies' futures, but frankly for the health plans and the healthcare systems and others. There's a lot of interests right now in health plans and health providers who sometimes don't see the same barriers that technology solution providers couldn't see. And sometimes, even if they can see them, aren't equipped to be able to kind of make the case and use the data to kind of provide a compelling story to say, look, this barrier is leading to this missed opportunity here. This solution, this handheld ultrasound, right, can't get to these caregivers because of this barrier. So my point is there's ways to influence payment and power, right? How policy is essentially shaped by being able to tap into the analysis of data by place.
It really sounds like data is the key here. Rishi, we have to bring our conversation towards a close here, but before we wrap up, I just want to give you an opportunity if our audience wants to connect with you. Where can they find you? Where can they find out more about what you do?
So www.healthbegins.org is certainly a good spot to start. Health Begins is the organization I lead, and we do a lot of this work helping plans, providers. I personally and our company does a lot of work supporting technology providers, connecting them to kind of the clients we work with as well and advising. So healthbegins.org is a great place to start. My social media handle on X, I'm Rishi Manchanda, and I'm also on LinkedIn.
Excellent. I know we're going to have a lot of new followers after today's podcast. I certainly learned a lot, and you really inspired me to think differently about what we do. Even at Clarius, I'd say we do a lot for global health initiatives internationally, and I'm going to come back to the rest of our team and try to challenge us to channel more of our energy also to taking care of our populations right here at home. There's a lot to be done in Canada. We do have a public healthcare system, and there's still a lot of gaps, and a lot of people fall through those cracks, and there's more we should do as a company, and certainly inspired me and I think other listeners here to think differently about data, about location, and use that as power to drive policy change, to drive business opportunities, and to drive better outcomes. So thank you very much for being with us today, Rishi.
Thanks, Ohad. Pleasure to be with you.
And to all of our listeners, thank you for joining us for another episode of our podcast. That's it for today. That's a wrap. Bye-bye.